Good evening, if there's anybody there. My name's Dr. David Molloy. For a long time, I've been medical director of the Queensland Fertility Group, and I gave that up last year, and now I've got an executive medical position with Virtus Health that cuts right across Australia, and right down and up the east coast of Australia. I started in fertility practice in the mid-1980s and have been a busy IVF doctor now for well over 30 years. I do some subspecialty work. I'm a busy endometriosis surgeon and a busy gynecological surgeon as well. And a lot of doctors around Queensland send me their more difficult surgery to do, particularly in the field of endometriosis and fertility work. So if you've got any questions that you would like to ask, I'll be very happy to answer them. So the first question I've got was from Megan, saying, are there stages of endometriosis? So how do you define endometriosis? There are 4 stages. It's an American classification, but it's used worldwide. So 1 to 4. 1's very mild, 2, 3 are moderate, and 4 is very severe. So in level 4, there's quite a high level of damage of infertility. It's very likely to have high level symptoms. Then there's a question from Tanya, how does endometriosis affect fertility? Well, we're not totally sure for all of the levels, okay? So if you've got level 4, you often have very high levels of pelvic distortion. You have got scarring around your tubes. Tubes might be totally blocked from the endometriosis. There may be big growths of endometriosis in the ovary that are very badly affecting the function of the ovaries. And that can be very bad, for example, on IVF programs if you've got endometriosis filled ovaries. The milder levels we're not sure about. There are a lot of theories as to why that is. It may affect egg function or the quality of egg production. It may affect things like tubal motility. For example, we know that there are more ectopic pregnancies in patients with endometriosis, so the tubes, perhaps in a subtle way, may function less well. And what we do know is that from quite a large number of studies that treating endometriosis may improve your fertility. So some of the association between endometriosis and fertility is a little bit intuitive in that people don't actually understand why the endometriosis can affect fertility, but when we treat the endometriosis, more people seem to get pregnant. There's a question from Rochelle here. Can pelvic inflammatory disease cause issues with undergoing the IVF process? Well, yes, it can. There's, of course, the reason that IVF was invented back in the mid-80s is there was this huge number of patients who had damaged pelvises from PID. And that sort of is a hangover from the sexual revolution of the 60s. So what a lot of infertility work is about is acting as a sort of social safety net for how people have changed their behavior and women have changed their behavior in the last 50 years. And in the 60s, with the invention of the oral contraceptive pill, there was a lot more sex. And with a lot more sex came a lot more PID. And those patients who, were teenagers in the 60s became to want to reproduce through the 80s. And there were a lot of damaged pelvises. 40% of patients on IVF had a damaged pelvis from PID in the mid-80s. And the late 70s when IVF was invented, the first baby in 1978. And so certainly that's why IVF was invented. But active PID is certainly very dangerous with IVF. So if you've got an active PID infection, active chlamydia, active gonorrhea, we try to do an egg pickup. The very, very high chance you'll end up with a very life-threatening pelvic abscess. Also, pelvic inflammatory disease can cause blocked tubes, something called hydrosalpinxes. So if you end up with a blocked tube and your tube fills with water, there's really, really high level evidence that can reduce the implantation of embryos. So when we put the embryos back with IVF, they will have a lower pregnancy rate. And what we do occasionally with these hopelessly blocked tubes is actually remove them for patients go through IVF. Fortunately, PID is pretty rare these days. We've got a much more sophisticated population. There's a greater awareness amongst GPs. Patients have STI checks much more frequently. And now it's rare for me to see a damage that's been damaged by PID. So Medi asked, is it necessary to wait a full cycle after second look surgery? The answer is yes. The pelvis is very raw still. When we do an egg pickup, what we're doing is we're putting a probe in at the end of the vagina. Needle goes through the vagina and into the ovary. Now, for patients who've got moderate or significant level endometriosis and we've taken the lining off the pelvis to get rid of the endometriosis, that needs to heal. Otherwise, what we do when we go in and pick up is put a needle straight through a very red and angry area. Through a very red and angry area, that it's like really going to your GP and going through an area of gravel rash. Okay, so it's not a good idea to do that. Okay. So yes, generally you do have to wait sort of a fairly you do have to wait a moderate time. I'm just going to get rid of this call. Great. Now there's another question then from Ashley. If male fertility isn't a contributing factor, what's the first best course of action, IVF or IUI, if the Clomid cycles have failed? Okay. Now, if you haven't got male infertility and you're at a reasonable age, then your choices of treatment, basically, let's go back a little bit. If you've just got a genuine fertility problem, and let's say you're under 35, the data's usually fairly good. So if you spent, say, a year and a half trying to get pregnant and you don't access any treatment, then your background pregnancy rate is around about sort of 4 or 5% per month if you haven't got any male factor, and there really isn't too much wrong. We just don't know why you're not getting pregnant. If you do an IUI cycle where you basically do it with timing and then you wash the sperm and you put the sperm up inside the uterus, you'll generally possibly double your pregnancy chance. So that'll come up to, say, about 10%. If you're having Clomid and you're just doing Clomid, what I call blind Clomid, no bloods or no timing, perhaps you might just be using the sticks. Generally, you only add a couple of percent to that pregnancy rate. And the Clomid's only helpful if you've got an ovulation problem. So if you've got reasonably regular cycles and you're taking a bit of Clomid as well, you won't get much of an increase in your pregnancy rate. If you've got no cycles or you've got very irregular cycles and you take Clomid, well, Clomid might give you that 4 to 5 to 7% pregnancy rate. IUI generally, with timing, will approximately double the pregnancy rate. Now, if you're under the age of 35, you generally should be getting around about a 40% pregnancy chance with IVF. So by and large, if you failed Clomid treatment, you would generally go to IVF rather than IUI because the increase in pregnancy chance with IUI is not going to be very high. There's a question from Laura here asking, will endometriosis come back once it's removed? Laura, we probably, with conservative surgery for endometriosis, we generally won't remove it all. And so the aim of most endometriosis surgery is to take you down to super mild level 1. You can very rarely look a patient in the eye at the end of endometriosis surgery and say, look, I've removed every spot of it, because there can be microscopic disease there. And you go back, if you go back and do another laparoscopy 6 months later, there's probably going to be 3 or 4 new spots. So what you aim to do, particularly in the fertility patient, is reduce the endometriosis load down to as little as possible. And then the patient gets pregnant. Now, when you get pregnant, particularly if you breastfeed, you'll get probably about a 70% resolution of the endometriosis. Still can get endometriosis. The endometriosis can keep going. About 30% of patients don't get cured by pregnancy and breastfeeding. And sort of that follows on a little bit with Belinda's question, can endo stage 4 come back after successful pregnancy? Well, the answer is absolutely, definitely yes. And of course, all of this is about timing too. So, it's not rare to do a stage 4 endometriosis operation, help the patient get pregnant either with or without IVF. The patient might then quite successfully go on and have another pregnancy. And, particularly if the patient's, say, in their late 20s, early 30s, and, I've been around now long enough to follow many of my own patients through, and then, but, 10 years after the pregnancy, they'll come back and the endometriosis will have recurred at that point. And very often, they might be, say, 42 with 3 children or 2 children. And what you'll do is at that point, perhaps do a hysterectomy or something like that as an end stage procedure for their endometriosis. And then there's a question from Elvira again, laparoscopic removal of endometriosis and FET. Generally, I'd advise the same time, which is basically a couple of cycles, 1 or 2 cycles. The pelvis is still very inflamed after the surgery. And so, it's really better to recover. Let your pelvis settle down. Particularly if you're having natural cycle transfer as opposed to a medicated transfer, then you would generally want to wait 1 or 2 cycles and just get your pelvis and your general health back into really good shape after the surgery. Tanya's asking how often you need to be checked for endometriosis with stage 4. It's an almost impossible question to ask. We're reluctant to do on-spec laparoscopy. Laparoscopy is still a substantial operation. Your first go surgery with endometriosis is your best go if it's done properly. And you tend not to go back and just randomly check in the absence of symptoms. Certainly if the patient's, going 2 or 3 or 4 years with, say, failed IVF or something, you might go back. But you tend to go more on the patient's symptoms. If it's asymptomatic endometriosis, that does make it, often a bit harder. Stephanie's asked, what's the pregnancy chance for women over 35 with IVF? And the answer is, well, it's very gradated, depending, because it depends how much over 35. It's, your pregnancy rates, perhaps in between, say, 35 and 37, sit around 30-35%. If you're over 40, 40 to 42, they're sitting down at about 15 or 20%. 42 plus, you're getting down to single-digit figures, sort of generally around about 5 or 8%. Leanne's asked a question, what's the relationship between endometriosis and adenomyosis? Adenomyosis is endometriosis within the uterus, and can adenomyosis cause fertility problems? So there's a big school of thought that suggests that adenomyosis actually causes endometriosis. So, for example, if you're a patient in Belgium or Holland, there's a really strong thought that adenomyosis grows out of your uterus, and particularly deep infiltrating endometriosis, like that can be in the pouch of Douglas or attacking your bowel or whatever, that actually comes from adenomyosis. Other people are less sure of that theory. It's sort of really confined, that theory is pretty much confined to sort of Western Europe, and particularly Belgium, France, and Holland. Certainly, I think adenomyosis may be involved if it's very extreme. However, adenomyosis itself is very common. If you have had a child or two and you do a scan of the uterus, you see adenomyosis very, very frequently. Adenomyosis itself is quite common as a commensal finding. And you might have a patient who's had 3 children, has a hysterectomy at 45 for, very heavy bleeding and flooding and clots. And the finding when you send that uterus to the pathologist is that they've got adenomyosis, and yet they've got no endometriosis and they've never had a fertility problem in their life. Can you have endo and PCOS? The answer is absolutely yes. And because of the abnormal hormone profile with PCOS, endometriosis is more common in patients with PCOS. So there is actually an association between endo and PCOS, and you certainly can have that, have the two actually at the same time. A question from Natalie. Is it necessary to remove bowel and bladder endo for future health if you have silent symptoms? I'm not sure what's meant by silent symptoms. That sort of means no symptoms, I guess. In general terms, the principles of endometriosis surgery are that you basically have maximal removal of the disease. Now, if you've got perforating endometriosis, in other words, endometriosis that is actually drilling its way into other organs like your bowel or your bladder, by and large, that endometriosis should be removed. Endometriosis is a pretty relentless disease process. It tends to keep moving forward. And so if you've got endometriosis causing, say, a full thickness nodule in your bladder, you're getting perhaps blood in your urine at the time of your period or whatever, then yes, certainly that should be removed. And certainly, with bowel endometriosis, it's a little difficult because if you've just got spots of endometriosis on your bowel, then it's hard to remove that. You actually should have some hormonal treatment to remove that. We don't chip away at bowels. If you try to, cut a little bit of endometriosis off a bowel, the patients can get a lot of trouble with bowel injuries. So you only tend to remove endometriosis from the bowel when it's fairly advanced, and if a patient's got a full thickness nodule in the bowel or has got distortion of the bowel. Ashley's asking, implanting 2 embryos in an IVF cycle have a higher chance of implantation or more multiples. You did get a slight tick up in pregnancy chance with 2 embryos, but it's not worth it. We have had a really, really solid project at QFG over the last 5 years to get the embryo transfer number down just to 1. In Australia, we've got the best embryo transfer figures in the world, and now something like 87% of embryo transfers in Australia are single embryo transfers. We took the figures out. So when I was medical director of QFG, and I made this a project, and we took all the data out over a 3-year period from about 2014 to about 2018. And basically what we found was that where we put 2 embryos back, and particularly with the improvement in pregnancy rates relating to blastocyst transfer, that the death rate for twins, the national death rate for twins in all of Australia, we've got all of this data, the national death rate, for all of Australia is about 3% for a multiple pregnancy for twins. In Queensland, we were finding that the death rate for twins was 1 in 28 babies died. Now, this is death over the age of 20 weeks of pregnancy. So you actually have to have a funeral. It's not like a miscarriage. This is actually a baby that dies and has to be, you have to manage the death. Now, the babies don't die in symmetrical pairs. What you find is that the pregnancy, what we did was we took out a figure. It's a really horrible thing to say, but it was basically a funeral rate. How many families had to actually have a funeral for one of their children? And the answer was 1 in 18 if you had a set of twins, because, the babies didn't die in symmetrical groups or symmetrical pairs. So, that's why we became so fierce about doing single embryo transfers, is because the death rate basically with twins, and by the time you account for that, you actually do worse even though the tick up in pregnancy rate might be higher, but in fact you take fewer live babies home. A question from Belinda. Major pain and endo symptoms after successful pregnancy. Can stage 4 endo come back again? Yes, certainly it can. And that's certainly can happen. Lovely messages. Thank you so much from Leanne and Beck. I'm terribly pleased to see that. It's just utterly wonderful to see messages like that. And then a question from Dominic about how quickly endo can come back after surgery. Well, as I said a bit earlier on, we don't really treat. We can't really guarantee to get it all back, so it sometimes can come back quite quickly. And indeed, it's very distressing. Sometimes you'll remove endometriosis from an ovary and endometrioma, and that's the most difficult spot to treat endometriosis, because the ovaries are full of hormone and it's very soft tissue, and you'll take endometriosis out of an ovary, and within under 6 cycles you'll see a new piece of endometriosis you'll see a new piece of endometriosis back really quite quickly in the ovaries, and that's the most difficult area to treat. And you worry a lot about ovaries, because every time you treat an ovarian endometriosis, you lose eggs, and you just got to be so careful with ovaries. Thanks, Leanne, for your message about your boys, and Kate, I'm really sorry to hear about your twin loss. Maddie, I don't know that there's much on endometriosis diets, to be honest. I think endometriosis is a pretty relentless disease process, and I'm not that convinced that diet will help you particularly. I mean, obviously diet and general health is important, and particularly if you're overweight, you actually have more estrogen in your body, and being overweight can certainly help endometriosis to grow with that extra estrogen. And a final comment from Ashley. We're looking forward to helping you. So look, I think we seem to have done our questions, and I'm very grateful to everybody. It's been nice. This is the first time I've done one of these. I guess you never would have picked that. Being a slightly older doctor, I'm just learning about things like Facebook and Instagram and stuff. In fact, we bought Instagram for Dummies the other day, and I'm slowly working my way through that. So look, thanks everybody, and listen, have a great night, and I'll look forward to doing one of these again.